My name is Alison O'Connor and I am the MC for this morning. And I'm very encouraged by the fact I haven't even had to ask for quiet. It's all just happened automatically. So welcome to this special event to celebrate the 25th anniversary of the Institute of Public Health, which has shaped health policy across the island of Ireland for 25 years. So I'm going to move it swiftly along. We have a lot to get into the allotted time. And my first task this morning is to welcome Professor Bernie Hannigan, who took up a role as chair of the board of the Institute of Public Health at the beginning of this year. Professor Hannigan.
Thanks, Alison. Good morning, everybody. It's my real privilege to chair the Institute of Public Health in Ireland. Though I was born and educated in this city, I've only ever worked in Northern Ireland or elsewhere in the UK. But from whichever jurisdiction you have come today, thank you for taking the time to attend this event, recognising the Institute's first successful 25 years. Though it's now 6 months since we celebrated the 25th anniversary of the Good Friday Belfast Agreement, the Institute's formation actually predated that momentous achievement. A potential downside of this timing is the Institute's absence from the administrative and political scrutiny of the agreement's implementation. However, the fact that the health departments, both North and South, continue to fund and support the IPH and use its outputs it is clear evidence of the Institute's value and standing. It's really a shining example of what can be achieved through sustained cooperation in areas that are important both North and South. So let's remind ourselves of the exact areas in which the IPH works. So sometimes the phrase public health is used to mean a publicly funded health system. But no, public health is policy, systems, processes, and practices in two specific areas of work. One is health protection, that aims to protect everyone against hazardous infections, chemicals, or radiation. The other is health improvement, enabling people to make healthy choices and to avoid illnesses resulting from what we consume, whether foods, other drinks, alcohol, tobacco, or other drugs, or other behaviours, such as how much exercise we take or how we interact with our environments. The Institute of Public Health focuses on health improvement, and we provide the best available evidence to policymakers, politicians, and people, and health professionals as well, of course, enabling people to choose the health-promoting options, and those must be suitable for each community and each individual, regardless of wealth, power, or location. But no system really is two discrete divisions. The COVID pandemic showed that a community's underpinning health and resources profoundly affect its ability to survive an infectious virus. The Public Health Reform Expert Advisory Group was tasked with identifying learning from the COVID response in Ireland, and its very good report, known generally as the Brady Report, was published just recently. I love the opening sentence of its executive summary. So it appears to upend what often characterises a health system, hospitals and patients, by stating that the health of a nation is protected by its public health system, working alongside its social care and primary health systems. The report goes on to say that hospitals and specialist units deal with serious illness when it occurs. So I believe the report's primary message is that the public health system must be the nation's priority investment in health. The public health system is vital for all of its people and is the real front line. The Institute of Public Health will continue its excellent work to support people's health, both north and south. I congratulate and thank all of the incredible people who made the past 25 years a success, and look to the current and future talent, now led by its fantastic CEO, Suzanne O'Connor, who are set to continue in the same vein as previously. Thank you for attending, and I hope you enjoy and participate in today's excellent programme.
Thank you very much, Professor Hannigan, for getting us off to such a very good start. And now I'm going to introduce a message from Professor Sir Michael McBride, a video message, Chief Medical Officer, Northern Ireland.
Good morning, everyone. Unfortunately, I'm unable to attend in person. 2023 is a significant milestone for the Institute, marking 25 years of working towards healthier populations in Ireland and Northern Ireland. The Institute was established with a remit to promote North-South cooperation for public health. The organisation greatly contributes to public health information and knowledge and has played an important role in growing a professional capacity within the area of public health while building strong networks both nationally and internationally. Over the past 25 years, the Institute has provided a solid evidence base and made recommendations on a wide range of public health issues. To name but a few, work on tobacco control, alcohol policy, and breastfeeding has been invaluable in supporting the Department's objectives to improve health outcomes. The Making Life Better strategy is Northern Ireland's overarching strategic framework for public health, and it commits us to creating the conditions for individuals, families, and communities to take greater control over their lives and to be supported to lead healthier lives. A tremendous amount of work has been undertaken by Suzanne and her team over the years to complement this strategy. We continue to work closely with the team and recently have begun to explore a well-being economy whole system approach across government with support from the Institute. Making Life Better provides direction to guide the development and implementation of collaborative action in government to both regional and local levels. The framework has been developed on an evidence-based theory of change, recognising that health and well-being and health inequalities are not just the outcome of the clinical services we provide, but are primarily shaped by many important factors including age, family, community, workplace, beliefs and traditions, economics, and physical and social environments. It was agreed in January that rather than continue with the midterm review of Making Life Better, which had started in 2019 and had to be delayed due to the COVID-19 pandemic, a number of initiatives would be taken forward on a cross-departmental and agency basis. These initiatives are aligned with the policy responsibilities of other executive departments to help enhance cross-departmental working and benefit from a collaborative gain. As you would expect, the health and social challenges that we face are commonly shared north and south of the border. The Institute is uniquely placed to help us tackle problems together, share knowledge, and best utilise the public health expertise that exists between us. As an example, North-South cooperation on addressing alcohol availability continues to be a cornerstone of our joint aim of bringing about a reduction of alcohol-related harm in both jurisdictions. I would like to pass on my thanks to the Institute for continuing to host the North-South Alcohol Policy Advisory Group. The strength and value of the Institute was further emphasised in recent years when we faced great challenges in exiting the European Union and the pandemic. Such considerable events highlight the complexities that we have to face together and the value and strength of our unique relationship. The COVID-19 pandemic has had profound impacts on health and well-being and the evidence is showing that the longer-term consequences could be driving further health inequalities. We need to work together to help to create the conditions to allow people to make healthier choices, encourage early intervention, and support those people who become ill to recover and to maintain good health into the future. I also must pay tribute to all those individuals from all over Ireland, north and south, who have served so diligently on the board of the Institute since its inception. I was delighted to see Professor Bernie Hannigan, a former colleague in the Department of Health here in Northern Ireland, appointed as chair last year. Finally, I would like to take a moment to acknowledge the diverse skills and enthusiasm that are often shown when we work alongside colleagues from the Institute. When focusing on specific areas of policy work, I know that teams in the department greatly appreciate the strong working relationships that have been nurtured over time, as well as the Institute's diverse nature and ability to adapt to changing public health issues as they become priorities. I wish you all a very successful 25th anniversary celebratory event, and I hope you enjoy the morning. Thank you.
Just before I move on to our next speaker, if I could remind you to put your mobile phones on, just to make sure that you have them on silent. The event is being recorded. So now to introduce you to Professor Breda Smith, who's Chief Medical Officer Ireland, to come to the stage now. Thank you.
Hello everyone, and thank you all, and thank you to the Institute for inviting me here today to celebrate this really momentous occasion. 25 years is a long time, and it's fantastic to be back in the place where it all started 25 years ago. So I am delighted to be here to celebrate this 25th anniversary. And first of all, I'd like to thank Professor Bernie Hannigan, the chair of the board of the Institute, Martin Higgins, the deputy chair, and Suzanne Costello, the CEO, for their invitation to me to join you today here in the Royal College of Physicians. So, how did it come about? How was the Institute formed? Well, it was formed during a key time in Irish history, the process to sign the Good Friday Agreement. And the establishment of the Institute arose out of a working group formed by both Departments of Health in the South and North and the RCPI. This sense of collaboration and cooperation regarding the governance and support for the Institute has continued. And I would like to take this opportunity to thank all of our public health colleagues in Northern Ireland who have worked in partnership with our public health colleagues here in the South via the Institute for 25 years, including my counterpart, Professor Sir Michael McBride, Gary Maxwell, and Brian Dooley in particular. The IPH was formally established through a memorandum of agreement between RCPI and the departments. As part of reinforcing our commitment to the Institute, we are presently now working with colleagues in the North to sign a new Memorandum of Understanding together with the IPH that will ensure continued good governance, strong departmental support and meaningful collaboration into the future for the next 25 years. The Institute of Public Health was set up with a view to providing services in support of public health activities on an all-island basis. As we know, the health and well-being of the people of our island is a priority in both of our jurisdictions, and a healthy population on both sides of the border is a significant societal asset, not just for prosperity, but for lasting peace. This means it is vital that we work together to proactively improve the health and well-being of the population of our shared Ireland, and also address inequalities that exist both sides of the border. And as Professor McBride was talking about our well-being economy, we have identified that throughout the pandemic, it is the well-being of our population that helps us to protect our population from emerging threats. Like a small virus, it knows no borders, and we face the same epidemiological and public health challenges on both sides of the border. The island of Ireland is a single epidemiological unit for disease control and population health. And as I said, COVID-19 sharply brought this into focus and also actually provided us a significant opportunity to further build our relationships and reinforce our partnerships. It also highlighted some challenges that we face working across two different political jurisdictions, which can offer different policy approaches and a lack of comparable health and social data. Avian influenza, likewise, is similar, and I was delighted to have attended a North-South exercise for avian influenza. This enables a one-island approach to our health security. Likewise, we should have a one-island approach to our health improvement. Addressing the data and information gap could prove a platform for greater cooperation. For many years, the IPH have led the way in developing mechanisms to overcome this challenge and is currently preparing a bid to the Peace Plus Fund to develop an all-island minimum public health data set and public health data strategy, which we support. The Good Friday Agreement provides significant scope for North-South cooperation to health, and to date, this has been focused on the very successful arrangements for North-South specialist healthcare services, prevention and early intervention projects through the COAT initiative. Some other examples include progress on tobacco and alcohol policy, such as a smoking ban, and policy proposals on minimum unit pricing for alcohol. And currently, parallel work is on way also in the area of obesity. The IPH also chairs the North-South Alcohol Policy Advisory Group on behalf of the Chief Medical Officers of Ireland and Northern Ireland, which provides a forum for discussion on policy developments on the island of Ireland. The group provides briefings to the North-South Ministerial Council and facilitates webinars, briefings, knowledge exchange, as well as opportunities for engagement with alcohol policy matters in Scotland, England and Wales. So the IPH is a key platform for cooperation and informed public health policy making. It has made a significant contribution over the past 25 years, and I wish the Institute well for the next 25 years. As I finish, I would like to welcome my colleague, Professor McKee, to Dublin and to the podium now for his next address. Thank you.
Well, thank you very much indeed, Breda. And it is an enormous privilege to be here with you in Dublin today. It's actually also a privilege to be back in the college because I've been paying my subscriptions as a fellow for many years and I hardly ever come here, particularly as now we have a female president. I know it's only been 360 years, but you never rush these things. But let's talk about the Institute. So in its 25 years, the Institute, I can tell you as somebody who works mostly in the international arena, has become an internationally acclaimed beacon in the public health landscape. So it really is a huge pleasure to be here to celebrate your success. Now, we in the European Observatory, a partnership that includes Ireland, also had a 25th birthday recently, a few weeks ago in Brussels. So I have some idea as to how you're feeling today. But it's not just the fact that the Institute is 25 years old. We're also celebrating, as Breda has said, the events that made this Institute possible. Now, I was actually in Belfast with friends on the day that people north and south voted to support the Good Friday Agreement. I'd left this island many years previously, so I didn't have a vote, but the sense of relief among my friends was palpable. A few personal reflections. Some of you may have read my account in the BMJ of growing up in Belfast, and this was written in response to Kenneth Branagh's excellent film. And my experience was very different to his. I came from a middle-class family living in a tree-lined avenue in South Belfast. But my parents were general practitioners working across the sectarian interface in East Belfast in what was a mirror image of Branagh's experience. So I've also seen at firsthand the consequences of inter-community violence, not just in my native Belfast, but also in Sarajevo, where I worked during the siege, in Israel and Lebanon, where I work a lot, and on the Russian-Georgian border. So these experiences have powerfully shaped my approach to life and explain why I was so willing, despite a horrendously busy travel schedule, to accept Suzanne's request to come here. Now, I've been asked to talk about the arguments for investing in health. And it may seem obvious to everyone here that governments should do what they can to safeguard and improve the health of their populations. I think it would be difficult for any politician, or at least one hoping to be elected, who would explicitly say that they are pursuing policies that are designed to damage health. But of course we know that far too often they do things that will harm us. Now, there are always excuses. They argue that they need to take other things into account. They mutter words about the economy or individual freedom, but they hardly ever set out a reasoned case for how they have balanced these competing arguments. And almost as bad, they often fail to do things that we know would improve health. It just never seems to be a priority. So maybe we do need to look again at the arguments that we use. Why should governments invest in health? Well, at this point, it may be helpful to provide a little bit of background. During the pandemic, Hans Kluge, the WHO Regional Director for Europe, who I advise, asked me to chair the Scientific Advisory Board for a newly created Pan-European Commission on Health and Sustainable Development. Now, the Commission was chaired by a former Italian Prime Minister and European Commissioner, Mario Monti. My fellow commissioners included very few physicians, or from people from the health community more generally, and instead we had politicians. We had 3 former presidents, 2 former prime ministers, people with expertise in finance, like Jim O'Neill, famous for conceiving the concept of BRICS when he was at Goldman Sachs, and experts in food, agriculture, and development. So our report had lots on the many threats to human health, from extreme weather events to cyber attacks, something that you know about here, and also to pandemics. It also set out a series of measures that are needed if we are to withstand them. Some are now being taken forward by WHO and some by the G20, although with the inevitable problems arising from Russia's invasion of Ukraine. But we also recognized that we needed, in our report, to make the case for health, and that's what I'm going to do here. So the first argument is an ethical one, the so-called golden rule, which appears in all of the world's major religions in some form or other. It can be summarized as saying that we should do unto others as they would want them to do to us. Now, this was, of course, why the earliest forms of organized healthcare in Europe were associated with religious orders. And, of course, there are different reasons why religious writers have proposed this rule. One is that by doing good, you will be, in this life, you will be rewarded in the afterlife, or if you're a Buddhist, if you're reincarnated. But another is that doing good to others helps us feel better. We are mostly, I say this with some reservations, having heard the speech by Suella Braverman yesterday, but we are mostly nice people, and we gain satisfaction from doing good things. And a third, of course, is self-interest, because for many centuries, societies have worked together to care for people with infectious diseases and mental illness, because those people themselves pose a threat to others. And finally, we act because when we look at those who are ill, we realize that it could be us. The philosopher John Rawls asks us to develop policies from behind what he describes as a veil of ignorance. We then don't know where we will be when that veil is lifted, and to some extent that was the case during the pandemic. And the choices we make will then reflect the possibility that it will be us who are at the bottom of the pile. Now, these considerations take us some way towards making a strong case for investing in health, but they're not enough on their own. First, they may not cut ice with politicians facing competing financial pressures, and second, they raise fundamental questions about who is included. Who are we who are inside the tent and who are those who are outside it. And I'm sad to say, as we know, this is a question that some people struggle with, including Irish gymnastics. A second set of arguments see health as a human right. Now, the right to health was established in the 1946 WHO Constitution and reaffirmed in the 1948 Universal Declaration of Human Rights. Everyone is entitled to adequate living standards encompassing health, food, clothing, housing, medical care and security, particularly when they face hardships or disability. Now, this right, of course, has evolved over time. The International Covenant on Economic, Social and Cultural Rights emphasizes everyone's right to physical and mental health. It sets out minimum responsibilities for states, irrespective of their resources, but also progressive realization as resources become available. Now, the responsibilities placed on states include non-discriminatory access to health services, especially for marginalized individuals, essential food, sanitation, essential drugs, and a comprehensive public health strategy. But we have to be honest that the exact interpretation of this is open to interpretation. Although the Covenant promotes international aid for countries that are unable to fulfill their rights, for example, it doesn't specify a procedure by which that assistance would be given. Now, more recently, the principle of health has become more clearly rooted in international law, reiterated in a series of global platforms. For instance, in 2012, the UN General Assembly emphasized equitable access to essential health services and medicines without producing financial hardship. But perhaps the most important, oops, have I gone too far? I should have had an SDG. But perhaps the most important is the 2015 Sustainable Development Goals, or SDGs, which reiterated the global health commitments, particularly in SDG 3, which I'm sure, as you all know, champions health and well-being for everyone. Now, I'm not naive. I'm not so naive that I think that governments are always persuaded by the commitments that they make in international fora. After all, I live in a country where a minister was willing to tell Parliament that he was willing to breach international law, albeit in only a limited and specific way. So we do need stronger arguments. So our third argument is that we need to invest in health if we are to achieve other policy goals. Now, back in 2006, we in the European Observatory worked with the Finnish presidency of the EU to develop the concept of health in all policies. Now, this is the argument that measures in other sectors, such as better housing or safer roads, are good for health. It picks up on the idea that we in the health system are constantly picking up the pieces after the failures in other policies. But more recently, in a Lancet paper, we've moved on to argue that investment in health is good for other sectors. Now, when we look at that, the main focus of the argument has been on health as a driver of economic growth, and this is an idea that gained momentum in 2000 following the report of the Commission on Macroeconomics and Health, which showed that poor health was hindering development in low-income countries, and also that investments in better health provided significant economic returns. But there were concerns about the relevance of those arguments to high-income countries where fewer people were engaged in hard physical labor. So that we addressed this in a study which we did for the European Commission in 2006, and we found 4 ways through which health influences economic growth. Healthier individuals are generally more productive. People in good health are more active in the workforce. Good health can encourage investment in education, in your own education, encouraging growth. And healthy individuals are more likely to invest in long-term projects like small businesses, anticipating that they will benefit from the future rewards. Now, we were able to bring together a lot of evidence to support these arguments. For instance, better health is associated with increased hourly wages. Poor health is associated with working fewer hours per week or retiring early. Chronic illnesses and disabilities can reduce one's employment probability, and adolescents in poor health are less able to benefit from education. So there's a huge amount of research that indicates that health investments, alongside those in education and in digital and physical infrastructure, significantly drive economic growth across nations at all levels of development. But while the argument that investing in health is needed to grow the economy is compelling, we have a problem. It involves spending money now for benefits that will come sometime in the future, and almost always several electoral cycles from now. So we need other arguments, and that takes us to health and security. Fourth argument. Now, Thomas Hobbes, the philosopher, argued that individuals surrender certain freedoms to their government, he was writing during the English Civil War, for protection from various threats. And this is the essence of the social contract. And this idea underscores the intertwining of health and national security, which we've seen especially in the way that infectious diseases can destabilize state functions, in the same way that military attacks can do. Now, the term health security broadly describes efforts to prevent, detect, and respond to international infectious disease threats, to minimize their socioeconomic consequences. We also know that over the past 2 decades, the connection between health and security has strengthened. The end of the Cold War shifted the focus to non-traditional security threats like HIV/AIDS, becoming a prominent concern due to its potential to weaken military and security forces. Events like 9/11 and the SARS outbreak of 2003 further emphasized the need for health securitization, reminding us of our vulnerability to disease and the interrelatedness of populations worldwide. We are all connected to each other, as we saw in the pandemic. But of course, we also have to reckon that with any discussion of international security, there is a tension between global and national interests. Now, the International Health Regulations, IHR, revised in 2005, epitomized this tension. They seek a global approach towards infectious disease control, but unlike their predecessors, they also allow non-state actors to report outbreaks that governments might like to keep quiet, perhaps because of a risk to tourist income. They ask governments to implement measures that they may not want to take because they threaten powerful vested interests. So there are lots of complexities involved in this argument, but it is important, and there are some genuine concerns, because global health security can sometimes suggest that it's only Western countries that need protection from outbreaks originating in poor countries. We also know that a security response must be balanced with civil liberties and provide protection for those who suffer from restrictions, as we saw during the pandemic. The involvement of police forces in some countries can deter certain communities from seeking healthcare and may even lead to attacks on healthcare workers. And as we saw really very much in some countries during the pandemic, it can also encourage the emergence of online armies of conspiracy theories and charlatans exploiting every opportunity they can to pursue their agenda. So this takes me to the final argument. And this is that many countries have seen a growing segment of their population becoming marginalized by economic and social change, such as deindustrialization, and this is leading to a waning of the social solidarity that is the foundation of the European social model. We have several warnings from history. We showed how, in the late 1920s and early 1930s, regions of the Weimar Republic experiencing austerity saw increased support for the National Socialist Party. And if we fast forward to the present time, my colleague Jacob Bohr has shown how deteriorating health conditions in the United States, the diseases of despair, presaged the shift in voting from the Democrats to Donald Trump in 2016. And in the United Kingdom, we showed how the disastrous EU referendum was driven to some extent by people voting to leave the EU in areas with those same deaths of despair, high drug-related deaths and suicide. We've also got good data from the European Social Survey that shows that poor health is associated with support for right-wing populist parties. This has very important implications, and especially these political ones are really key. Right-wing populist parties often sideline health priorities. They just don't agree with the things that we all believe in. They choose instead to invest in areas like criminal justice, which may further strain health systems as police and prisons become the fallback for health system inadequacies. These parties also adopt exclusionary policies, negatively impacting already vulnerable groups and doing nothing This is the paradox, nothing for the care of their own supporters. So in this way, deteriorating health can easily instigate a vicious downward cycle where support for certain policies worsens societal health. Now, what I've done so far is to offer you a menu of arguments for health. Which ones you use will obviously depend on who you're talking to. But what happens when a government doesn't listen? What can ordinary people do when their needs are being ignored? And this is a question that we in the public health community try to avoid. Many of us live in fear that we will be accused of being political. As you can see, I don't share that fear. But too often we meekly submit to those who tell us that we should stay in our lane and stick to the epidemiology. And it's obviously a particular concern for our colleagues who do work in government. I'm not naive. Many public health professionals do, and they can't speak out. When do you go public with your concerns? And of course, this audience will be very well aware of recent circumstances where there have been conflicts between public health professionals and politicians. So Carol Brain and I in the BMJ the other day wrote that because in the United Kingdom we now have the new GMC guidance on creating an environment in which people can speak out, then we in public health, who are public health medics, should actually adopt the idea that David Oliver came up with in clinical specialties, an I Spartacus moment. We should all speak out together, because if we do, then it's going to be very difficult to discipline or dismiss all of us. But what responsibility does the international community have when a government fails to protect the health of its people? You might wonder why I'm asking a question like that today here in Ireland. And in response, I would simply draw your attention, if you're not already familiar with it, to a recent article in the Belfast Telegraph. And its author, who many of you will know, Sam McBride, tweeted, "There's an end of days feel to Northern Ireland right now. A sort of half-hearted anarchy pervades us. As swathes of what society takes for granted are breaking down. The scale and nature of the crises now unfolding will have profound political consequences." Now, of course, he's not just talking about the health service, although that features prominently, along with Loch Ness. Some international instruments, like those related to nuclear security and trade, do have robust enforcement mechanisms, but others related to health are inevitably weaker. International law is stricter on counterfeit banknotes than it is on counterfeit medicines. But even if the community of nations is limited in what it can do, we as health professionals and representatives of civil society can speak out. We can speak out about the situation in other parts of the world, and we can speak out about the situation when it's on our own island. Thank you very much.
Now, I think you'll agree that Professor McKee has given us enormous food for thought there, and we're going to have a panel discussion now with contributors from the political, health, economics and community arena. If the panel would come up to the stage, please. And we're going to discuss what we've just been hearing. And each panel member, we're going to begin with each panel member taking a few brief minutes to give their own response and to make some of their own points. And we will have some questions, and then there will be time afterwards for questions from the floor. So I'm just going to sit down here now. So I'll just briefly introduce you to everyone here. Just beside me here, we have ESRI health economist Dr. Anne Nolan. Beside Anne, SDLP, MLA and health and wellbeing spokesperson Colin McGrath. Adeline O'Brien, who is CEO of Empower, a local development company situated in Fingal. Then we have the Sinn Féin TD and health spokesman David Cullinan. And beside David, we have Joanne Vance, who's Director of the Community Development and Health Network. So I'm going to start by asking you, Anne, to kick things off for us, please.
Thank you, Alison, and thanks very much to the IPH for the invitation to participate today. So, I'd first of all like to respond, I suppose, to Martin's wonderful speech. And I suppose, speaking as the economist in the room here, I'd like to pick up, I suppose, on some of the points he was making around the importance of health investments for the economy, but I would also argue for society, I suppose, more generally. I work a lot on research on the social determinants of health, so I'm very familiar with the direction of travel between our social and economic conditions and how that influences our health and well-being. But I think as Martin has very elegantly and eloquently said, the relationship also works the other way. And this has really, I suppose, been shown very strikingly using a lot of research from the UK, from the birth cohort studies. So these are the studies that follow cohorts of children born in particular years, so let's say 1946, 48, or 58, and follow them right through their lives. And you can see really clearly there that poor health in childhood sets children and young people on a trajectory that influences their health, their social and their economic chances right through their lives. So there's really nice evidence from the 1958 study, for example, that shows that poor health in childhood is associated with poorer educational outcomes, poorer employment opportunities, and poorer social outcomes, even into people's 40s, 50s, and 60s. We here in Ireland, I work a lot on the Growing Up in Ireland longitudinal study of children, and also the TILDA study, the Irish longitudinal study on ageing. Obviously, our Growing Up in Ireland cohort are slightly younger, so it's going to take some time for us to see the effects of poor health in childhood manifesting, but we do see it already coming through. So, for example, in one of our cohorts, we see that people in poor health, they've lower educational attainment, even at the age of 9. So we see it coming through even at very young ages. But I suppose I want to make a broader point. It's not just about educational and employment opportunities, but it's also about wider social contributions and contributions that people make to their economies and society. So we know from evidence from the TILDA study, for example, that not only are people who are in poor health less likely to work, so they retire early, and obviously for their own well-being, that's a poor outcome, obviously for society at large. But they also are less likely to participate in other activities that are less monetized, but are equally and really important to society. So things like caring. They're less likely to care for spouses, they're less likely to care for other people in their community, for grandchildren, for example. And that's a huge contribution that older people potentially make to society. And finally, as well, they're less likely to engage in other activities like volunteering. We know that people in poor health are less likely to volunteer. And again, that's a huge contribution to society that tends to be not monetized, but I think reinforces this point around the importance of investments in health.
Okay. Thank you very much, Colin.
Yes, thank you very much. And I suppose begin by saying happy birthday to the IPH, and thank you very much for inviting me down to participate in this and maybe give a perspective from the northern end of Ireland and maybe more parish closer to where Professor McKee is from. There's really a few elements that struck me from the remarks. And the first really is that concept of why should government invest in health, and that's fairly obvious that it's about attaining better outcomes for the population. But I do feel that it does fall into two different tiers. First of all, there's that reactive health service, which is when people get sick, when people are unwell, and we need to have a service that is there to be able to deal with them. But then we also have that proactive health service, which should be about trying to offer advice and guidance to the population to enable them to stay well. And it was always taken many years ago by Dr. Alan Stout from a GP in the north who's part of many committees, that said in his practice, if he went out through the front door and he went 1 mile to the left, the life expectancy was many years greater than if he went out through the door and went 1 mile to the right. And that shows just how there's a difference within communities, difference in their backgrounds, and that can have a greater impact upon their health outcomes and their life expectancy. I suppose the difficulty is that we seem to have governments that focus just on the reactive health service, that it's about providing those health services for people when they get sick, and there's not just as much emphasis on trying to advise and help and shape communities to enable people to stay better. And for us in the north, that is not something that's new. Professor Bengoa published a report about the state of our services and the way to move forward back in 2016, and a huge effort of that was about trying to prepare the health service for the future. And of course, a greater emphasis on that was trying to keep the population healthier. I was taken as well by the remarks about it's the European Commission on Health and Sustainable Development. And again, just that crossover that if we have too many politicians in the room, we often get a different type of agenda than if we had the health professionals in the room. And that's something that we're grappling with in the North. There is a reluctance to let go. There's a reluctance to see health services being reshaped and transformed. And that is often down to the fact that politicians can exert that level of influence over policy, which then has an impact on where health services are. So I think we do need to try ourselves to be able to take our hands off a lot of the future decision makings in terms of health and allow a greater input from the health professionals. But I don't know if that's necessarily one that's going to be successful, given that it would require the politicians like ourselves to actually take those key decisions. In terms of the health and the investment in terms of other sectors, yeah, I think that is critically important, because we know that good health drives a better economy. We know that people will learn better if they are in better health. We know that they're better able to work if they're in good health. But sort of a thought that I had in that is the difficulty whenever you have coalition governments, and especially if you want to take, some people may say that coalition governments are very difficult in delivering policies, because there tends to be a silo mentality. The political parties from their own perspective will drive the policy of the department that they're actually in charge of, and you really would need to get a sort of golden pack of ministers from one party that are in charge of economy, that they're in charge of finance, that they're in charge of health, that they then would be able to affect that change. But if you want to see dysfunction in terms of silo coalition government, just have a wee look at the North, because it's it's coalition government on speed whenever there's so many parties round the one table, and getting them to try agree on a policy that everybody can go off and do their own work is very difficult. But I can see that in the North there is an effort to try and move towards a programme for government that is outcomes based. And I hope that within there is the seed that can allow us to say, if a healthy outcome for everybody in society is an aim, then all ministers within all departments should be working towards that, and doing so on a collaborative basis. But government in the North would be a good start, never mind actually getting ministers to work together. And then I suppose finally it is just really, I met recently just this week with a whole range of health organisations in the North to hear exactly what their concerns. And the thing that struck me most from that was the concept that is that really they wanted to see healthcare policy driving funding, but they're concerned that what we see is funding that drives the healthcare policy. And I think that is a difficulty. I think we should be trying to shape our policies and then put the money to it. But I think we have a long way to go before we reach there, certainly in the North.
All right, thank you very much, Colin. Adeline.
Thank you. I suppose my response is in the context of working in social inclusion, anti-poverty and local development. And in answer to your question, like what can ordinary people do when their needs are being ignored, I think find your extraordinary. There's many extraordinary people living in communities, and I would say that what you do is you get political, you get informed, get organised and get local. So we're a firm believer in the local development network that no matter what the national policy might be or the intention, that responses are best when they're locally based. And a kind of an example close to my heart across the local authority jurisdiction in Fingal is that there's a variety of disadvantaged and affluent communities, and if you were to have a one-size-fits-all approach to implementing any kind of policy, you'd look at a town like Balbriggan, which is the youngest town in Ireland, highest percentage of under fives. We have Corduff, then most disadvantaged community in the country, probably much older population, and then you look at somewhere like Mulhuddard with a cluster of lone parents and coincidentally the highest rate of cervical cancer in the country. So the notion that a one-fits-all policy could sit onto local communities, it's just a disaster. So we would say that real change for real people happens at a local level, and to be proud and to embrace that. And if you look to the how piece then, well how would that happen? And you look at the response that we had nationally to COVID, for example. So every local authority area had a COVID response forum, and national policy, national data, information was cascading down through a local authority structure. But it was the local community groups at grassroots levels that actually implemented change, that supported people to understand policy. And the nuances across particularly disadvantaged communities, where very often there's language barriers, there's literacy barriers, there's financial barriers, and there's also a disconnect within their local community network. So we would have seen that no matter what policy was agreed or decided, or what had to be implemented, it only ever happened with real people, real change in local community areas. And it only happens when you adopt a place-based response. So we would always argue that there needs to be a place-based response for most things that happen across communities. But you need strong collaborative local networks for that. You need really strong, well-funded, organised community groups, because it's community groups who give voice to the most disadvantaged. And to recognise that these hard-to-reach people that we talk about all the time are actually finding it hard to access our services. So are the populations that we're talking about in terms of health inequality hard to reach, or are the services that we provide really hard to access? When you don't have access to transport, you're a lone parent with many children to mind, and you can't get 5 buses to an appointment, where again there's language barriers. We found our experience during the COVID pandemic, we had to translate information that was coming from government. We're a local community group, and we had to translate information coming from government into about 12 different languages, including Romani. And then you look to the how-to piece, and you have to ask yourself, over the last 12 years, when you see what's happening in terms of policy and funding related to that in government, this move to centralise and privatise community and social services is a complete and absolute disaster. Generally, because we know at the spirit level, equality is good for everybody. But if you're living in a very disadvantaged area and you're living on the margins, having a privatised service in your area, it's not cost effective for a lot of the big home care providers. We see it in a lot of social services to operate in disadvantaged areas. The other thing that I would say is this Healthy Ireland programme. We're very well intentioned, but it is confusing the difference between health and well-being at a local level. Local community groups in disadvantaged areas are really struggling to understand what is the difference and how best to implement it. So again, I'd go back to saying we need to think about targeting local areas for local responses to make sure that health inequality is properly addressed, because what's happening at the moment, it's just not working. So sorry, I wish I had better news for everybody, but I don't.
We might get some time afterwards to tease some more of that out. Thank you, Adeline. And now, David.
Thank you, and can I start by thanking the IPA for the invitation in the first instance, and Michael for your presentation. Lots of ingredients in your presentation that are thought-provoking for all of us. It might surprise people to hear me say that there's one part of Michael's contribution that I didn't entirely agree with, and that was the point where he said that politicians don't see healthcare as a priority. And I include in that, by the way, current and previous governments in this state. I think people do see healthcare as a priority, but I think where there is some truth in what Martin is saying is that very often my experience of healthcare in this state is that we have a lot of plans, a lot of strategies, which very often don't get resourced and don't get delivered. And people can wear that badge in this room from a whole range of areas where we put a lot of effort into developing the strategies, but we don't put the resources behind it. And I think that frustrates people. I was at a conference recently, and they had a picture up as a backdrop of a car that didn't have 4 wheels, but was held up by policy documents. And I think it summed up, maybe for me, a lot of problems in healthcare, where politicians are very good at always coming up with new ideas and policy documents and launching things. In reality, the focus has to be on the practical. What can we do? And that's certainly what I would want to do. I also think it was important to have the 2 CMOs here, and Breda came into her job, I would argue, at the right time for her. But I think COVID also is a good example of an area that exposed the best and the worst of our healthcare systems, north and south, and those relationships within the healthcare systems and how we see public health. And I think by and large in this state, the politicians were supportive of public health in very difficult circumstances, really traumatic circumstances for people, and really tough decisions had to be made. And I think that cross-party support by and large for public health was really important. It did expose, I think, some challenges north-south, and we all are aware of those. But it also, I think, showed us that how we view public health is something that we have to get right in the future in its broader sense, because Martin again featured on not just how we see healthcare delivery in terms of services, but external influences like housing, poor quality housing, poverty, inequality, educational attainment, climate action are all really important for any Minister for Health or any government when they're looking at delivery of healthcare. I just want to focus maybe on two kind of areas in my opening remarks, and one is because of the role of the Institute, which is the North-South All-Ireland cooperation. There are lots of positive examples that we can give in this space, in cancer, in cardiac care, in children's healthcare. As we know, there's lots happening on the innovation space and the research side, but there's huge more potential, and that's something I think that a lot of people on the panel certainly would agree with. Obviously, we need an executive in the north up and running as soon as possible. There are lots of problems in the healthcare system in the north, and the waiting times are higher than we have in the south. So there's obviously a lot to be done. But for me, north-south cooperation has to be something that the politicians have to be part of, but so too do the clinicians. And I always make the point that if you left north-south cooperation on healthcare to clinicians, it would happen tomorrow. It's already happening. They know what to do. They want it to happen. There's huge innovation, there's huge opportunities, but very often the block comes from the political system for sometimes obvious reasons and sometimes less obvious reasons. So I think that is certainly something that we obviously need to have more of a conversation on. For me, the two big priorities in terms of north-south relationships and how we fix the problems in healthcare is actually understanding that lots of the things that we're talking about are the same. So the Ben-Gur report that Colin talked about is very similar to Sláintecare. Very similar principles in terms of ending silos, integrating primary acute community, which in my view is really important, because if you don't understand the impact that the lack of capacity in primary and community care is having on your acute hospitals, you'll never sort the problems in emergency departments. A lot of it is actually what happens in primary and community care. But I think that those two reports are really important, and we need to kind of be joining those up. Workforce planning is critical, and it was really thankful to see that outreach from the government in the south as well, in terms of funding training posts, for example. Like that's we need to do more of that. But there's no reason why workforce planning can't be done on an all-island basis. We see it with more training capacity in McKee University and so on. I think we need to do much more of that. And then the other piece that I think is missing in the south, where we are weak, and Martin talked about the importance of data, which is really important for any healthcare system. Clinicians will fight and argue till the cows come home, but they will agree when good data is put on the table. But we're years behind in this stage in relation to digital transformation. We don't have unique patient identifiers, electronic patient records. We know all the problems with the systems that don't speak to each other. And I would say that needs to be something that's a priority for North-South relations. And the final point I'll make, because there was some commentary in recent weeks as well when we launched our own proposals in terms of Sláintecare and having a universal healthcare system. I think it's important for people in this room and for people to hear that if there is to be a change of government, and obviously I would like to be a Minister for Health, there is consensus on the direction on how we configure health services. A universal healthcare system funded through general taxation. And there's lots of different opinions on how we can configure the system. But I think that if we try and change now and move away from Sláintecare and try and turn the Titanic again to look at either a social insurance model, that would be a major mistake. I think we have our direction to travel, and we have to keep pointing in that direction. And that means continuing to reduce the cost of healthcare, improving capacity, not just in hospitals, but in our acute hospital system, and then reforming through the regional health areas, which I think will be hugely powerful if we can get them to work well. So I'm actually excited about the potential that comes from all of that.
All right, thank you very much. Joanne.
Thanks very much indeed, and thanks to Martin. It was really refreshing to hear your three arguments for why government should invest in our health. Health is a public good, just as you say, like education as well. And it's public health is a key pillar of population health, which is the way we're all working now. We've got great policy alignment, as you're saying. We know what needs to be done. And we know that this is ultimately about the health of people, communities and society. I really liked the way that you reminded us of the universal right to health. It's so important because when you really unpack what that declaration is saying, it's saying that people have a right to participate in their own health. That boils down to the very essence of it all, and it boils down to why the Institute of Public Health had the good sense of inviting the community response here, because that's where we work. We work in communities, we work with people, and I really appreciated the fact that you put our work into a political and socio-economic and into that global context, because working here in Ireland, whether it's north or south, whether it's in a neighbourhood or a local council area, we really need to be very brave about public health and how we move forward, that we all need to remind ourselves of the context that we're working in. The Community Development and Health Network was formed just around the time of the peace process, and it came together because of community workers working in the most disadvantaged areas across Northern Ireland, and the key focus of their work was poverty, because without addressing poverty, you were never going to address the health and well-being of our society. And I think that is something that we need to be, the COVID, it reminded us just of the stark inequalities in our society, and we have growing disparities now down to the issues that Martin talked about around the types of jobs that we all do, our caring responsibilities. And Adeline and I know from the work that we do in communities, we know who bears the brunt of all of that. And yet we have got really good policies, and Sir Michael McBride mentioned they're making life better. And in making life better, there is a strong strand of that which is about community development approaches to address health inequalities and to improve the health of the population. And what does that mean? Well, it's what Adeline's talking about there. It's about how the system can use all of the assets, use the assets of its people, use the assets of community, and use the knowledge of communities to make better policies, to plan services better, so that people are not left out. So thank you for reminding us, and that's all I have to say for the moment.
Okay, thank you very much. I mean, I think you'll agree, a huge diversity of views there. But I suppose if I was to start with you, Anne, I think you would very much say that where is any of it without measurement and your baseline? And maybe you'd talk to us a bit about, why that's important and have we enough of it?
Sure. So I think Adeline and Joanne very eloquently, put forward, I suppose, the challenges they see on the ground and trying to implement sort of national policies. And we've also heard about there's been multiple policies that have been put forward. But I suppose, underlying all of that, it might be the sort of the boring point to make, but we really need to be able to measure our progress and to monitor in order to sort of see whether these policies that are being implemented are being implemented appropriately and whether we're achieving the goals that have been set out in them. And I suppose I'll give an example of, I suppose, the data environment that we're working with here in Ireland, based on a bit of work that we did with the Institute a couple of years ago, looking at inequalities in mortality. So mortality is the sort of the ultimate health outcome. It's a really good marker of the health of a population. And the Institute had done some work over 20 years ago now, a really important piece of work where they had looked at inequalities in mortality, north and south. But they had used data up until, I think it was about 1998. And obviously, particularly in the south, in Ireland, obviously the economy and society had changed massively since that time. So we worked with the Institute to look at the extent to which inequalities in mortality had persisted, whether they had narrowed over time. But we couldn't do that. We couldn't actually look at time trends using the data that we had. And that's a real major gap. So we cannot say, for example, after the financial crisis, what happened to inequalities in mortality in Ireland. We can say what they're like at this point in time, but we cannot look at the time trends. And that's a huge gap in terms of our evidence base and in terms of trying to design policies and figuring out where we should be intervening in terms of the vulnerable groups. But I suppose there are positives. In Northern Ireland, they do have actually a really good data environment for doing this type of work. So what they do have is what's called the Northern Ireland Longitudinal Study, which many of you here might be familiar with, whereby there's a really large sample of the population that are linked to the census of population. Mm-hmm. And you get really rich data there. Obviously, it's appropriately anonymized and there's appropriate access controls, but it really enhances the knowledge base that people have and that policymakers have for making these types of decisions.
That sort of feels like it naturally leads on, Colin, to ask you, if Anne is highlighting there how much better the information is it your experience that having that information is good for policy making, for informing policy?
I suppose fundamentally, yes, it should do, and it should be the driver of what makes the difference in terms of health policy, and I think it would derive and drive the decisions that are taken by officials as they prepare those documents and prepare the information that is then presented to a minister and then ultimately to an executive. But I suppose we always have to look through the prism or with the glasses on of the actual administration that we have in the north and how that can be quite dysfunctional because decisions are often taken with a very heavy political slant of whichever parties are in the bigger sphere, whoever it is that has that department. We have a large political ensemble in the north, if I could put it like that, and therefore decisions that policy would take, which maybe are based on facts and figures and on the data, ultimately can be trumped by the strength of the political representation on the ground in a particular area. Now, we have a term that's often used as a criticism, especially from journalists towards politicians, which is the concept of the parish pump sort of policy approach. And I disagree with that just in the sense that I think, if you elect parish representatives, then you expect parish pump politics. So there has to be a reality check that that's going to happen. But I think it was a former constituency colleague of mine from the DUP, Jim Wells, when he was health minister, that used to quote that there was something like 228 buildings within the health estate in the north, ranging from hospitals right down to sheds. And he said that if you were to simply close one of those sheds, there would be a protest that would have all of the representatives from that area looking to have that shed to stay open. So I think there is a maturity that needs to go that allows us to use that data to allow that data to drive forward. There is, I think, some political consensus within the north amongst the parties that they will try to take that step back and allow the data to drive and inform the policy. But there's going to be the proof of the pudding will be in the eating in that.
Indeed. So David Connan, I suppose the elephant in the room at the moment, if you look at the headlines, we have a budget down here coming up next Tuesday. The headlines are talking about a health overrun of 1.1 billion. Martin in his speech talked about spending money today, but it could be a couple of election cycles before you see, and this idea of having health in all policies. But how do you sell that when there's this sort of sense of a health budget already gone crazy?
Well, I think the starting point there is that we have to look at what's happening internationally. So a big part of that cost overrun is to do with health inflation, which is running internationally at about between 17 and 20%. And every health system in Europe is struggling with the same difficulty. Part of the problem is also that the health service was underfunded last year, and that was acknowledged by the head of the department in relation to what's called existing levels of service. So the money that's needed to meet the pressures in terms of demographics and inflation and pay and so on. And it is a problem. And obviously that level of deficit on top of whatever new measures is difficult to sell. But equally, I think people understand that if we want to improve healthcare services, if we want to increase capacity, it does cost money. What we have to do, and I think that's Martin was kind of touching on this, that, you know, should we be looking at healthcare through the prism of the overall budget cycle every year, and it's at the whim of a cabinet or government in terms of what's available, or should we look at it differently? Politicians have no choice in reality but to look at the income which is available, and then we have choices to make in terms of, we'll present our budget today, so I actually have to leave here at 1 o'clock to launch that from the health side. So those obviously opportunities are there for parties to put forward ways in which we can raise revenue as well. But it is challenging. We have big problems in healthcare across the island. So I acknowledge as well that in the north, for example, we have major problems with waiting lists in emergency departments. We have a big debate in Britain. Martin talked about the Tories in Britain, and anyone that saw the conference there in recent days will be hoping that reign of power will be coming to an end very quickly. But one of the big debates that's happening there, and one of the changes that I hope that we will see, is that there will be a re-energising of investment in the NHS in Britain, which obviously will have implications for the north as well. But it is difficult, and you know, as somebody who wants to see more investment in healthcare, I'm conscious that we also have to achieve reforms, and we also have to make sure that we're getting bang for buck. And I think that's where regional health areas, we put forward propositions like a single integrated waiting list management system, and lots of other areas where we can reform the system to make it work better, and not just spending more money, but more money is needed.
Okay. Joanne, can I ask you, I suppose it's a more broader question, but from your perspective of working, your community perspective, what do you see as ultimate success in public health?
I was interested in what David was saying there just around the budgets, and the thought that came into my head was prevention. You know, and what do we understand by prevention and early interventions? And very much in the community sector, we take it in its widest sense. So, you know, investing in early years, investing in young unemployed people and giving them training and education, taking the long-term view of what we need to do now so that society is better in the future, so that waiting lists comes down, people are less sick, people are more empowered to take control of their own health. That all requires a look right across the system, the Health for All policies. And we need to look at how we're spending our money now and ensure that we are sharing resources much better. And that includes the resources that are being distributed at the local level and the national level as well. And I'm sure it's not about, it could be about savings. It most definitely will be effective and more efficient if we did that. So we have to look at the budgets differently. And I think we can learn some lessons from how we all had to act during the COVID period, where we collapsed the hierarchies, where we stopped thinking about the strategists, the decision makers, the implementers, and we were all in it together. We planned together. And in planning together and innovating together, I think you can make a real difference and a real change. And I think that we do have an opportunity to do that. But we need to get the headspace, we need to get the ways of working to do that. And I also think that we have lots of good tools like the data. So if we can take from our really good examples of how you involve and engage people in designing prevention activities, it's great. But if you look at the north at the moment and you look at the budgetary crisis, You take the Department of Health's budget, for example, although what I'm talking about is all the budgets. If you look across all the budgets, it will be the prevention activities that will be cut. So that we have to stop that. That is nonsense.
That it's the first to go or to be targeted. Adeline, from when your contribution earlier, I got a sense, and you can correct me if I'm not correct, a sense that of feeling that communication, you felt that maybe what you were seeing is not being either not being communicated, or that when you're on the ground you're not being listened to. Did I pick that up?
Yeah, well, it's a hard one to figure out because, you know, health inequality exists forever and a day, and it's still there, no matter how many discussions we have about it. What we're seeing on the ground, I suppose, and we would always see it, is this notion of equality, you know, doesn't mean the same. So when we look at how people access services, so it's about everyone having equal access to service. So it's about, you know, tending to everybody's different needs equally rather than doing the same thing for everybody. And that's what we would see happening quite a lot, and we saw it in COVID as well, is that kind of the same information would come the same way for everybody, but it takes kind of local knowledge and very expert local community groups to be able to translate that into what it means at a community level. So it goes back to that notion of our people hard to reach, our services hard to access. And very often we find, particularly among the travelling members of the travelling community, Romani, new people arriving into the country, international protection applicants, they find it extremely difficult to access services in this country without the support of paid professionals working in the community sector. And, you know, one thing that struck me was, you know, the rapid response to the Ukrainian crisis. It was quite remarkable in this country. But it also, I had a curiosity around the Department of Social Protection, which quite rightly had reception centres in the airport, understanding that if you have to access services in this country, you need to be registered with the department, you get your PPS number, and everything flowed from that. That doesn't happen for Romani people who travel into this country. Other transient populations don't get access to GP services, basic primary care services, because of this habitual residency condition. We see that with international protection applicants. So there's an understanding of what needs to happen in order to access services, but it's just not translating down into the local community. And that push to privatise and centralise social and community services has broken the system. Because there was, in the late 90s, there was a very well-functioning community development system through the local development network in Ireland. And over the last 12 years, it has slowly been dismantled. And it's a huge
Briefly, before we were chatting before, and Joanne was mentioning COVID, but you had a very good example of what Colin was talking about, the doctor he knew if he walked a mile one way or walked a mile the other way. You were talking about something in your area during COVID. It was to do with grocery shopping. You might just, and I'm going to come to questions on the floor then.
Yeah, so in Fingal, you know, there's two areas. There's Castleknock and there's Corduff, either side of the M50. And, you know, we saw some people found COVID as a way to slow down, step down, make banana bread. It's all very good, go for your walks. The experience that we found in terms of Corduff and Mulhuddard in particular was we had people living in overcrowding situations. It became a tinderbox, living at home. And if you were fortunate enough to have, you know, a bit of jingle in your pocket, you could bulk buy all of your groceries, and we saw shelves were emptied out, and, you know, it wasn't that, oh, well, I'd prefer to get this bread, but it's all sold out, so I'll get that bread. It's very often there was nothing left. So if you're living hand to mouth and you're living week to week, you don't have the option of bulk buying. You have to stay within the confine, cut your cloth. So we saw lots of people who social welfare payments eventually started to land, you know, people who used to collect it by cash eventually started to land. And then very often there was no food left in the shop. So we set up food banks as a response, one because there was low availability of food, but then there was also the other. But yeah, very, very different responses within like 2 or 3 miles in a small area. So,
Now, if you'd like to ask a question, we do have a roving microphone. If you would like to say who you are, if it's to a specific member of the panel, or else we can just put it as a general question.
Thanks very much. I'm Sheila Gilheany from Alcohol Action Ireland. I was tremendously interested in the discussion. One thing I just wanted to draw a little bit more attention to was the commercial determinants of health, which I didn't really hear so much about to begin with, although Martin, I think you are alluding to that when you're talking about the difficulties in political decisions. When we talk about preventative actions, which is absolutely core to public health, a lot actually comes down to who are the players in the health sphere. And one of the big players are the commercial actors who are there. We know that a third of deaths globally are caused by 4 industries, alcohol being one of them, so you're not surprised I'd point to that. And I'm just sort of wondering, how can we know the things that can work, and these are actually cost effective, they're cheap, they don't cost money, so when we're talking about trying to save money, it kind of, I suppose I'm frustrated to some extent that we haven't had more discussion on the cheap things. Ban on advertisement of junk food, just as one example. Extending provisions, or rather trying to restrict availability of alcohol through something like the sale of alcohol bill. So I'd just be interested in particularly the politicians and your views on that.
Okay, all right. Colin, would you like to give an initial? I might go to David then on that.
Well, I suppose initially the thought is that, like everything in life, it's about a balance. You don't want to simply ban everything or prohibit everything, and then you can sometimes make it somewhat more attractive. My background is in youth work, and I knew there was nothing like saying to a group of young people, don't walk down that corridor, to see a whole crew of them walking down that corridor. But I think if you take that principle and move it up into community and society level, there can be elements where people don't like to be told what they can and can't do. I think the method, or what I mentioned earlier about that silo thinking, I think we do need to maybe look at closer connections between education and health. We have a great opportunity through education to be able to actually work and ingrain facts, figures, thoughts, considerations, but that'll not work for everyone. There will be some responses that are required. In terms of the North, we would require legislation to follow on from that. I know that there has been discussion about a minimum unit price for alcohol, etc., and looking towards, I think, really Scotland as an example from their interventions. But the difficulty that we have is that the real discussions about the impact of that, the real considerations and interrogations of those various, the outcomes of those really takes place once a bill is presented and it goes through its various stages. We really do feel short in the North that we don't get that opportunity to progress bills, to have the conversations.
David?
Yeah, I think public health should trump commercial interests. I think that has to be our starting point. There has been some measures that were brought in the South that weren't extremely popular. The minimum unit pricing of alcohol being one, we supported it, even though from some quarters it was seen as unpopular. And to go back to that issue that was raised of balance, you can look at it from the point of view of balance, but at the end of the day we know that the 2 big killers are cancer and cardiac disease and many others as well, but they're 2 big ones. And we know that alcohol consumption plays a huge part in all of that, and there's a lot more that we can do. We have banned advertising in that space in this state. We brought the sugar tax in, so there are measures that were possibly seen from some as unpopular, but were the right things to do. So I think that comes down to political will and being brave enough to make those decisions. And we saw it with tobacco use and the moves that were made across the state and Ireland, across the world. Ireland was a leader in that. So my approach to it philosophically and politically would be public health always has to trump commercial interests. And where commercial interests push back against public health has to win.
I think music to the ears of this room. There, Fenton, just in the middle row there.
Fenton Howell, public health doctor and tobacco control advocate for many years. And it was Martin's last comment, David's comment there, really, that felt I should ask this question, because I would say for all my working life, I would have been trying to encourage ministers for health to increase the price of tobacco at every budget. It's a thing that ministers can do. Sometimes they do it, sometimes they don't. Price is the single biggest factor influencing people's decisions to smoke after their addiction. And tobacco causes roughly about 50% of all health inequalities that we experience. Yet, time after time, so when a government proposes an increase in the price of tobacco, nearly always, the opposition politicians, be they left-wing or right-wing, oppose it, nearly always. And that, to me, is striking, and it occurs right across the way. So their concern for health inequalities disappears when they think they might be able to have a cut at the other side. Mm-hmm. I think that's part of the problem then that we have, is that you say one thing when you're in government, you say something different when you're in opposition.
Thank you, Fred. There's somebody just there with their hand up. There's a pen in that hand. Yeah.
Thank you very much, Catherine Riley from the Irish Heart Foundation. And really, my comments really flow from Sheila's and from Fenton's. I know, Martin, your keynote address was "Should governments make us healthier?" and shifting the focus of public policy. And I suppose the main agenda is obviously prevention, and it's even moving from the discourse on individual responsibility and telling people what to do, that we actually create healthier environments. And that comes from public policy, it comes from prevention and those type of investments, and it's really critical. And we talked about Sláinte Care, and Sláinte Care was very upfront in talking about prevention, health and well-being, and making the funding available. And it was spoken throughout the event here today about making sure that the investments are done today. It mightn't be popular to put a lot of upfront investment now for something that might not reap the rewards for the current government. The following government could be 10, 20 years, but they are the things that are going to are going to save money, save health in the long term. And Sheila mentioned the commercial determinants of health, and I do welcome David's comments that public health should trump commercial interests, because for most of us here, or anyone who's familiar with the lobbying register, we see the amount of lobbying being done by commercial interests. And organisations like ourselves who have public health at heart, who have public health interests at heart, we don't get a look in with public health or with officials, with ministers in some of this lobbying. So just going back to Martin's comments, should governments make us healthier, shifting the focus of public policy? How do we shift the focus of public policy to prevention in real terms, and not just that curative care in primary care, waiting for people to get sick? How do we look at those commercial, social, economic determinants of health and ensure that it's not just lip service to prevention, that around creating healthier environments from the grassroots up, that we actually secure that, so that here in 10 years we're not talking the same thing? Okay.
I might put that, we're close to time, and as Deputy Conlon mentioned, he's has to leave at one sharp. But I might conclude to Adeline and Joanne, in terms of how you see what was just referred to there in terms of the implementation and doing it successfully.
Yeah, I think we'd naturally look at place-based response. I think we've lost that sense, even though we talk about the community and voluntary sector in Ireland being quite distinctive and unique. I think we've lost the value and the importance placed on place-based responses. Now, that doesn't mean there has to be, myriad of millions of responses, but where there are flashpoints in the country or there are particular areas of disadvantage, to unapologetically make a decision. There's a serious issue here in this community in relation to this, and you have that strong local collaborative network where the agencies come together around that. It is happening all the time. We've established health action groups in Balbriggan, we have Healthy Mulhuddard, and it addresses other kind of well-being and inclusion issues, but health is at the front, so we've called it Healthy Mulhuddard. It then cascades down to a better life for children and families who are part of the programme in the initiative.
Literally what it's saying on the tin. Thank you, Joanne.
The way I would approach anything like this is thinking about the social determinants of health, including the commercial determinants of health. And I think your response, you were kind of answering the question. So your own question, I think that we need our public health frameworks to take account of the key determinants of health. We need to think about how we all interact from the community level, people in communities up to the people who design services and policies, and how they include people in their thinking. I think with around the evidence base as well, that I'm kind of losing my train of thought now about the evidence base, but I think that the answer to the problem is pretty multifaceted, and it involves education. And it involves changes in policies. But fundamental to all of that, it needs to have people at the heart of it. So there's no point in talking about people who smoke or drink too much or eat the wrong foods without involving them in the conversations about why decision makers make the policies that they make around protecting their interests, and also finding out from them what actually works. And I think what Adeline is talking about is in the Healthy Mulhuddard, and there's other really good examples across the country of how people can take the policy, take the evidence, and design really good programmes to work in an inclusive way with populations who are experiencing the worst health and the worst health inequalities.
Okay. So that it can be done and done successfully.
It is being done. We just need to ramp it up and join the pieces together.
I think that's a nice positive note for us. I'm afraid we've come up against time. I would like to thank Anne, Colin, Adeline, David, Joanne, and particularly thank Martin for giving us so much food for discussion. I think we could be here for double the time. And thank you all for your attendance here this morning. Thank you very much.